Good afternoon, everyone. Thank you for being here. I'm going to take a personal moment of privilege before we do any activities or any introductions. And I'm going to ask for a moment of silence for the events that occurred yesterday in Uvalde, Texas. We lost 19 lives of children and 2 adult lives. And so if you will just indulge me for a moment in bowing and praying and supporting the families, the victims, obviously, and also the community. Thank you. Thank you for giving me that opportunity. So first of all, welcome. My name is Dr. Ryan Meyer. I am actually the president of the American College of Physicians. I am a private practice internal medicine physician practicing in Nashville, Tennessee, with a focus on primary care. Today, you will hear a variety of experts and opinions to talk about the value of primary care as it relates to our healthcare system, our very complex healthcare system. But before we begin, I am going to ask that everyone in the room mask yourselves. If you're not eating, not drinking, or not speaking, we will ask you to mask yourselves to protect not only yourself, but also those around you sitting in close confines and quarters. The American College of Physicians is a co-founder of Primary Care for America. Primary Care for America 22, Seeing the Possibilities, will be our conference today. And the American College of Physicians is proud to be a co-founder of Primary Care for America. ACP, or internal medicine physicians, are physicians that actually apply scientific knowledge and clinical expertise to the diagnosis, to the treatment, and the compassionate care of adult patients across the complex spectrum of health to illness. And we have 161,000 members in the American College of Physicians. That includes practicing physicians, the related subspecialists, residents and fellows in training, and also medical students. ACP, along with other members of Primary Care for America, really feels strong about amplifying the value that primary care has for our healthcare system and also the value that it has for our patients, most importantly. In primary care, it's been undervalued for many years, and it is now time to enhance the investment in primary care. We know from a growing body of evidence that primary care is high-value care. It decreases mortality. It decreases total system costs. It improves patient satisfaction, and it provides just the fundamental and foundation to the healthcare system. So we know that the challenges that face primary care physicians today are too common and too much. In my practice, every single day, I'm dealing with the complexities that involves patients who are left in the middle and sort of physicians trying to navigate and help our patients to the best of our ability. Whether it's negotiating with a lot of healthcare stakeholders like insurance companies, whether it's helping our patients navigate the complexities of a very complex healthcare system, whether it's the lack of resources from social determinants that really affect the outcomes of our patients, whether it's the interference of clinical decision-making and physician autonomy as it relates to ordering diagnostic tests and prescribing medications. There's a lot of interference that comes between the physician and the patient. It is because of those reasons that ACP has taken a lot of pride in promoting a change and improvement in the payment structure and paradigm for primary care, making primary care more attractive for our medical learners and students who are trying to decide on their career choice, and also encouraging new innovative models as it relates to patient care for better outcomes and better access for our patients. At this time, I would like to introduce Dr. Clive Fields, who is the CEO of VillageMD. He will be engaging in a discussion with Dr. David Blumenthal, who is actually the CEO of the Commonwealth Fund, who will be joining us remotely from Boston. And with that, I will turn the mic over to Dr. Fields. Thank you.
Dr. Myers, thank you very much. And just a quick thank you to the ACP, the AFP, and to Sean Martin for bringing this group together. So it's a real pleasure today. I get to talk to Dr. David Blumenthal. So David, welcome to the crowd.
Great to be here. Sorry I couldn't be there in person.
No, I'm sorry you can't be here. I was saying to somebody, it's a little bit of a Clint Eastwood moment for me, but I'm not sure if you're allowed to say that in Washington, D.C., so hopefully people won't take that the wrong way. So let me, I could spend the next 60 minutes telling you what Dr. Blumenthal has accomplished, and I'm going to try to kind of pick some highlights and do that over the next 30 seconds and really dig into some of the comments and thoughts that Dr. Blumenthal has about not just the future of primary care, but in particular an article that he recently wrote for the Harvard Business Review that talked a little bit about what many of us are seeing as the next wave of primary care. So Dr. Blumenthal is currently the president of the Commonwealth Fund. He was previously the National Coordinator for Health Information Technology and was also the Sam Thiel Professor of Medicine and Public Policy at Harvard. So David, I'm going to give you a clue here that the last thing that I'm going to ask you is how you got the nickname DB2. So that might actually give you some clues who I've been talking to before we had a chance to talk today. Before we look forward at where primary care is going, I'm going to dig into a last line that I just introduced you as, which is the Samuel Thiel Professor of Medicine and Public Policy. I think a lot of what we forget in primary care is how important mentorship is and examples that we actually provide to our patients, to our colleagues, and to people who are considering a profession in medicine. And David, I understand that Dr. Thiel had a significant influence on your life, and I'd love you to share some of those experiences.
Well, thank you. And again, it's great to be with you. And I should say I'm a proud, longstanding member of the American College of Physicians. I am a primary care physician. I began my primary care residency at Mass General Hospital in 1975. And I saw patients pretty much continuously until I went to work in the Obama administration in 2009. So that's an over a 30-year run, over 40-year run. So I can understand the dilemmas that face people like yourself and others in daily practice. Dr. Thier was someone who I came across first when I worked in Washington as a Senate staffer, and he was president of what was the then newly formed Institute of Medicine. He was an internist, had been chief of medicine at Yale, was a kind of phenomenon in the early, one of the youngest chiefs of medicine ever in an academic medical center of that repute. And he was successful just about everything he touched, but also a demanding person, great intellect, very probing, believed in the Socratic method on steroids. He was known as, but to some at Yale when he was making rounds with medical students, as Syncope Sam, because he was such a tough questioner. But he had great values, and he believed in people like myself who wanted to mix careers in medicine with careers in policy, and contributing in more general ways than they could in the very valuable and important and essential day-to-day practice of medicine. And so he helped me along the way, and then eventually was my boss at Partners Health System when I was a professor of medicine. And when he retired, a chair was named after him, and I was very fortunate to be asked to take my place as the first holder of that chair. It's now held by Atul Gawande, and who, of course, is on leave working for USAID.
Yeah, you're describing a physician who was probably practicing population health well before we thought of that word, somebody who recognized the importance and the value of individual patient and provider relations, but also the impact that a doctor can have and that many of the doctors in the audience today can have in in places far greater than the individual exam rooms that they work in. The other thing, David, that I have to ask you, so for the last 25 years, I've been cursing my electronic medical record. And I understand that you might actually be the guy that foisted that on me. Any truth to that?
I don't think if it's 25 years, you can't blame me for it because I only got into this in 2009. But yes, I used an electronic health record at Partners Health System at Mass General for a number of years before I went to work for the Obama campaign. And what I like to say is that I am not a technologist. Actually, my wife takes care of the computers at home. But as someone who had used a record and had practice experience, also management experience, I felt like I could understand the challenges and the value of electronic health records. I am the first to admit that we have not fully realized the value and that we are in a transition period where I think most people would agree we can't live without them, but it's very hard to live with them. I should also add that I have 2 children and a daughter-in-law who are physicians, all of whom have to use an electronic health record that I inflicted on them at Partners Health System, now MGH Brigham, and they are still willing to let me come for dinner. So there you are.
Well, you did something far better than me because I have a daughter who's graduating from law school next week, so I couldn't talk any of mine into med school. So clearly, your example was better. So one of the areas that I know that you've written a lot about is the undervalued and underappreciated primary care workforce in this country. And it's not hard and it's unfortunately too easy to look at the news and see see 2 particular areas in the area of mental health and the area of health equity, and how that could be addressed in a different way by the tens of thousands of primary care doctors who pick their specialty because of an interest in a holistic approach to prevention, to wellness, and to proactive care. And you've been writing about this, as far as I can see, for 20 years. And we still haven't recognized or appreciated what the primary care workforce could bring to those 2 areas. I'd love you to tell me a little bit or talk a little bit about the barriers that you've seen and maybe the wins that are now at our back.
Well, you've captured the dilemma. It's a dilemma I experienced. It probably was exaggerated because I was at a tertiary quaternary care facility and I was part of a pioneering training program that was started by my mentors in primary care. We were a strange species at Massachusetts General Hospital in the 1970s when I began my training. And I don't think people knew what to make of us. There are 2 key elements to the undervaluing of primary care. One is undercompensation, and the other is lack of respect and appreciation for the incredible challenges, intellectual, personal, and emotional, that are part of being a primary care physician or nurse practitioner or any practitioner of primary care. So I think both of those have to be addressed. The simplest one conceptually is compensation. We have a biased, entrenched, and incredibly resistant system for setting comparative rates of compensation for specialists and primary care physicians in the United States. It's uniquely dysfunctional in the Western world. If there were some way to get past it, I think it would make a big difference. And it is inherently political problem and needs to be addressed politically. And we have not cracked that nut yet. So that's number one. Number 2 is the prestige and importance. And I think that value-based payment, properly implemented, putting primary care physicians in a position of authority and of helping patients navigate the healthcare system, would do a lot for changing the respect with which they are regarded by specialists. It would, I think, require specialists to deal with them on a much more level playing field than we have seen in the past. Now, I was a navigator in a gatekeeping setting at when that was fashionable in the 1990s. It was not a comfortable situation for me, but I think it was because there was no support, no systemic support, no data to help me be a better choice maker for my patients. I got no information on the comparative costs or quality of care of alternative referrals. That kind of information, together with feedback on cost of care and continuously through better data systems, I think could help primary care physicians do what patients want them to do, which is give them advice and help them navigate the shoals of our incredibly tortuous healthcare system.
So, David, we spend a lot of time, and I never really thought about this before, we spend a lot of time talking about the undercompensation of primary care physicians. Is part of it really the overcompensation of specialists, or is that somewhat heresy to really talk about? And is that a third rail that nobody wants to go to?
It's both and. So the primary care physicians in the United States are paid pretty well, absolutely, compared to those in other countries. But they are paid, but the differential is less. Specialists are better paid everywhere, but the differential is less. And somehow places like the Netherlands and the United Kingdom and France and Germany have created an ethos in which primary care is respected sufficiently so that they are able to recruit into those cohorts. Now, that's not to say that other places are perfect, but they are better. They serve their populations better than we are able to do with our under-resourced and really handicapped primary care system.
You know, David, I had a chance this morning to spend some time calling on some of our elected officials, some senators and representatives, and from both sides of the aisle. And what I find when I'm in Washington is that nobody disagrees with the pathway to a more effective, more efficient healthcare system. And that is one that is more primary care centric, more proactive, more prevention focused, more risk stratified, more team based. But I've been coming to Washington now for, I'll bet 20 years, saying the same things and hearing them or saying them to people who nod in agreement. Clearly, there have been some changes over the last 20 years in terms of payment formulas and regulatory relief that are moving in that direction. But given the amount of time that you've spent, both in government and in public policy, what are the changes that we still need to see come out of this city in particular to move to a system that we all seem to agree is the system that we should be promoting?
Well, one of the reasons I wrote the Harvard Business Review piece that I wrote that you mentioned, which for those who do not necessarily read the Harvard Business Review, as I'm sure is true of many in the audience, raised the question of whether the private sector, companies like the ones you started, and other actors, including some very big ones like Walmart and Amazon and CVS Aetna, whether they are now going to take the initiative and be the source of the solution to our problems. One of the reasons I did that was because of my frustration with the process that you just went through, which is making the case to our national leaders. Our national leaders, of course, agree, because no one disagrees with the idea that people should have a caretaker, a physician or nurse, who they feel they trust and can use to manage their day-to-day healthcare problems. Everyone believes that. And frankly, the people on Capitol Hill have them. So they're not missing. They're not experiencing that feeling of loss or absence. It's when someone actually proposes a change in compensation that takes money from one pot and puts it in another that they get antsy. And they get, frankly, when the cardiologists and thoracic surgeons and radiologists and dermatologists come to town, it's very uncomfortable. And they all know those people too. They have their dermatologists and they have their cardiologists and they have their urologists. So it becomes a kind of make this go away kind of problem, because I really don't want to deal with it. I don't want to choose one of my physicians over another, and I'm just going to nod and say yes and leave things alone. The solution, the reason why primary care disruptors from the private sector make sense is because they have understood that primary care adds value that's not captured in the current compensation system. For all the reasons that were noted in the introduction, there's money on the table waiting to be harvested if you could put primary care in charge. And private capital can do that. Public policymakers have trouble, but private capital sees the opportunity. So they're willing to put money down up front with the hope that by cutting unnecessary referrals, unnecessary hospitalizations, unnecessary emergency room visits, that the total bill will be less. The difference between what it costs in the regular sector and what it might cost in their companies is going to go into their pockets, and they're going to be able to share it with primary care physicians and keep them motivated and happy and make their investors happy. That is what's happening. It's the idea that there's money on the table, that the fee-for-service system as we know it is leaving to specialty care and hospitals who are paid more in the United States than they are anywhere else in the world. So I never have been particularly interested in for-profit medicine. But you know, the old definition of insanity is doing the same thing again and again, expecting a different result. We've been doing the same thing again and again, like your visit to Capitol Hill. We haven't gotten a result, and this is an alternative. So I think that's what's happening right now. There are real dangers with the widespread for-profit ownership of primary care. One of them is that the startup companies get bought and sold, leadership changes, the founders in the companies, like yourself, like some other people I know, they're often their primary care physicians. They often have values that are not driven by Wall Street values. But on the third resale, it's not clear who's going to be in charge. And it's not clear what's going to happen to the long-suffering primary care physicians who now are watching a different set of priorities running their work. And boy, I'd much rather have professionalism in charge, which is what a well-compensated fee-for-service system might provide.
Now, David, so I'm going to dig into that HBR article, but I'm going to take you back a little bit and ask a couple more questions over what we've all lived through the last 2 years with the COVID pandemic. If there's ever been a canary in the coal mine about the lack of investment in primary care, it's hard to imagine that this pandemic has not revealed that. But I look back at where we were, and our office, unfortunately, diagnosed 4 of the first 7 cases in Texas. And I remember running around my office trying to call the Harris County Health Department, who closed at 5 o'clock, because that's what you did. You closed at 5 o'clock. And trying to get a definition as to what was close and prolonged contact, because nobody knew what close was or prolonged contact was. But I think over the last 2 years about how an investment in primary care and in public health resources could have made a difference over the last 2 years in reducing some of the staggering morbidity and mortality that this country has experienced. And I think about 1 million people dead from COVID. I think about the absolute disruption to not just this country, but to the world that we live in. And if that didn't wake up the folks in this city as to the need to pick a side, and if it's a specialist versus a generalist, whether it's a facility versus an office-based procedure, what do you think it's ever going to be to really get those folks to look at the dermatologists or the radiologists or the American Hospital Association and say, there's a finite amount of money to spend, and we believe we get greater value here than there?
Well, there's a bunch of points you just made. One important point is that we suffered during the pandemic for the lack of an adequate primary care capability. The second point you made is that there is a lack of connection between the public health organization, the public health system in our country, and the delivery system at every level, at primary care, but also at for nursing homes, for hospitals, for ambulatory surgical centers. At every level, public health and the delivery of care are separated by a huge cultural and economic gap that is unfortunate, and much greater here than in places like the United Kingdom, for example. So you made a complicated point, and by the way, the Commonwealth Fund, which I run, is about to release a report on what it would take to get a effective national public health system that works together with the private health system in the future. So we are very much aware of this issue. What it would take, I think it would take a breakthrough, kind of like a really effective outflanking movement of the resistance to change in primary care of the type we've been describing, whether it comes from the private sector or through some unexpected revolution in the public sector. I can't be sure, but I'm right now a little bit pessimistic about the public sector. But that's number one. Number two, it would take a substantial investment that seems to be against the tide right now in national politics in our public sector investment in healthcare. And we now spend, I think, about $19 per person nationally on public health.
And that's an annual number.
That's an annual number.
That's not a daily number. That's an annual number.
And we spend, I forget the number, but it's probably on the order of $15,000 per capita on healthcare. Mm-hmm. Those are where we're. So, talk about imbalance. I think that we need to readjust that investment, and doing that is as tough as getting primary care compensated adequately, but it's another item on the agenda. When you drill down into what that investment has to be, it's all kinds of things that touch primary care, like data collection. When you found those 5 patients, there was no way for you to communicate that information electronically to the Harris County Health System, because your practice may, if we're lucky, be linked to your hospital or to other data exchanges, but those are not linked to the public health system. So we are at ground zero with respect to data availability that enables us to know what you knew as a community physician and to use it for the public purpose of protecting health. That needs to change also. So I think there's an investment in the private practice of primary care. There's need for investment linking private primary care to public health. And the public health system needs to be able to take the data you want to send them. And there's a whole nother conversation about the 19th century level of automation in data in the public health system right now.
So David, you used a couple of words there. You used the word outflanked and the word revolution. Those almost sound like military terms. Should we in primary care be thinking that this is a war that we're in, that we're just not bringing the right weapons to? Or is this something that we should be thinking of differently than that?
So I'm lapsing into military terminology because I've been listening to a book on World War II. So it's infected.
Hopefully one of Stephen Ambrose's books.
No, it's another one, but it's very good. So it's helpful to think about the military analogy because what it means, outflanking means coming at something from a different direction. And that's what's interesting about the private sector investment in primary care. It's a different direction. It's potentially disruptive. Another reason why I have been a strong advocate of public release or public availability of patient information and transparency, as uncomfortable as it may be for practicing clinicians, transparency for patients into their electronic health records is the hope, which may be improbable and is certainly complicated, but the hope that patients can be a more powerful presence in the healthcare system. I had a conversation with a senator once about this issue, and I was able to make the idea of giving him control over his health information tangible. So we were talking about this, and he said, and like many senators, he has a local healthcare provider, but he also goes to Mayo Clinic. So he said, you mean if I had my data, I could give it to Mayo Clinic when I go there for my annual checkup? And I said, yes. And the result of that was some of the provisions in the Cures Act, which has facilitated the availability of information. Now, all physicians are very sensitive to their patients if they're good physicians. They may be too busy, they may be stressed, but if they're good physicians, they listen. And if they start hearing from their patients that they want something different, that may affect their behavior. And I think that might be true of specialists, and it might be true of hospital administrators and managed care leaders. So I'm hoping that patients can be part of the solution. Another flanking movement.
So David, when you said transparency to patients, I mean, we worry a lot about transparency between providers, but one of the most challenging things in primary care over the last number of years has been transparency that a patient has to their own record. And I think about conversations 4 or 5 years ago where nobody wanted to record a diagnosis of chronic kidney disease or morbid obesity for fear that it would offend a patient who would actually see that in their record. And I can honestly say over the last 3 or 4 years that those conversations are becoming far less frequent, and that physicians are becoming more adept at describing what is chronic kidney disease and why it is important to be in the record, and what is morbid obesity and what you can do about it. So that type of transparency that you describe, and obviously that you have been a leader in creating and driving, I think ultimately is driving conversations between patients and providers that maybe wouldn't have happened in the past, would certainly have been uncomfortable, and are now something that can't be avoided. So the idea of transparency, the idea of interconnectivity, and those are the kinds of things that I know running an organization like Village are just critical to driving results across our populations. So I'm going to read a quote to you that came out of your HBR article. HBR, which I did not know, stands for Harvard Business Review. I went to school in Texas, and so when people like David say that they went to school in Boston, I used to think that they didn't want to say they went to Harvard, but I know now what they're saying is they hope you misunderstood and thought they went to school in Austin, which is where I went to school. And so I appreciate the humility. But this is a quote. It said, "Never before have the titans of capitalism shown such interest in the humble family physician. And as a humble family physician, and as the son of an even more humble family physician, I thought to be in the same sentence as the titans of capitalism kind of made me puff my chest up a little bit. But you went on to really say that this most recent wave of, and primary care consolidation may not be the right term, but this recent wave of interest by, as you mentioned, the Walmarts and the Amazons and the Walgreens, which is a strategic investor in the company that I work with, and the CVSs, was really going to lead to one of three results. And the first one would be that primary care doctors would be used to drive people into retail stores to buy more pantyhose and People magazine. And I think in your article you said that's clearly not a good outcome. The second one, which was one that we unfortunately have all experienced, would be that the consolidation of resources of provider resources could be used to actually drive up fee-for-service rates through stronger positions of negotiation. And I think we've all seen that happen, and many of us cry loudly when we see it in our own communities. But the third one, I think, is the one that's most interesting. And that is that bringing these titans of capitalism together with primary care resources would bring capabilities to a primary care workforce that would allow them to accept risk, to take capitation, to invest in technology and data and analytics, and truly live the role that primary care could be in the communities that they serve. And I think all of us in this room, and certainly in this audience, which is a little bit biased, aren't that interested in outcomes number one or outcomes number two, but we're really interested in outcome number three, and many of us have spent the majority of our career driving in that direction. What are the odds on this one? I mean, we've all seen kind of the payers take charge and not do such a great job, and we've seen hospitals take charge and maybe not do such a great job. And in all honesty, we've seen governments take charge and maybe not do so great job. And this is kind of feels like the dawn of the primary care opportunity to actually step into that void. So what are the odds? What do we need to do to actually drive the odds to outcome number three? And how good do you feel at this stage in your career, and we're not far off in terms of our stages of career, about that outcome coming to fruition in a time period that we could see?
Well, the United States is a remarkable country in many ways. It's remarkable in the sad ways that your opening speaker talked about today, the events of the last 24 hours. It's remarkable in its willingness also to innovate. We don't accept the past as constraining us for the future. So we are innovating in primary care. We're doing stuff that has no precedent, not just in the United States, but anywhere in the world. So whether you like it or not, the members of your audience, if they're participating in the kind of experiment that you are, they are settling the West again, if you will, going past the Mississippi into uncharted territory. And who knows, really? I think that the one thing that is positive about this is that it may align incentives. So the people like the leaders of Walgreens or the leaders of CVS, Aetna, or maybe Amazon, they're very clear-eyed. They're not captured by traditional prejudices about whether specialists are important and primary care physicians aren't. What they see is dollar signs. They think that you can save money and they can have some of it. To get there, they have to put you at risk. They have to get you to share their incentives. And I think they'll get there. What I don't know is whether they will turn the screws so hard that eventually you will have to change you will have to compromise your professionalism, or you will feel compelled to leave in order to protect it. Aligning those incentives is great when they are aligned for the same purposes. And I don't know whether, let me put it differently. Capitalism is capitalism. It's about the bottom line. It's about the investors and getting their return. We shouldn't count on it being tenderhearted.
Well, David, I'm going to ask you the last question that I started with, and that came from one of our board members who said, you got to ask him where the nickname DB2 came from. And he said, and if you've got time, ask him what was that grudge that Hillary Clinton held for all of those years?
The first question I can answer, David Brailer was the original coordinator for National Health Information Technology. You don't need me to outline the alphabet there. He was DB1. And I was David Blumenthal, the second national coordinator. Actually, I was the third, but the one before me was a temporary replacement. And so I was the second formally appointed national coordinator. So I was DB2.
Got it.
David Brailer was a great innovator. He founded the office. He had no money. I walked in and I just was swimming in cash. So I think David had paved the way for me, and we've had a nice repartee around this. So I'm not sure what Hillary Clinton's grudge is that you're referring to. I don't know Hillary Clinton, though my wife was a classmate of hers at Wellesley. I did see her at the 50th reunion. I shouldn't have said that because that says something about my wife's age that she may not want me to divulge. I could make something up, but I think that wouldn't be respectful of your audience.
I will not ask you to do that. Well, I will say then thank you, and that you will be DB1 in the eyes of this audience for years to come, and I will share that with the original DB. But really appreciate you taking time out of your day joining us here in DC from a distance, and thank you both personally and professionally and for this audience for your commitment to really being a voice of reason in primary care as we chart somewhat uncharted territory. So thank you and have a great day.
And I thank the members of your audience for the good they do every day for their patients.
Thank you.
Thank you.
So Sean just gave me a chance to kind of comment a little bit about the work that we do at Village and how it ties into the conversation that we just completed. At Village, we are one of the organizations that Dr. Blumenthal just spoke about that is committed to a primary care-driven, proactive and preventative focus in the delivery of healthcare. And we at Village are excited to be many thousands of physicians strong, taking care of about 2.6 million patients, and strategically partner with Walgreens to bring comprehensive primary care to neighborhoods throughout the country, with a real focus on eliminating some of the health equity issues that face all of us in our practices today. So, Sean, thank you very much for the opportunity to meet Dr. Blumenthal today and the opportunity to address this audience.